All right, thank you very much. This is definitely the biggest and the fanciest room I've ever presented to. So, just to get that out of the way. But I'm a PhD student at Princeton. I'm presenting on some work that I've been doing for the first chapter of my dissertation, looking at climate change and health transitions with a case study using mortality data from Antananarivo, Madagascar. And this is, outside of South Africa, the first long-term study of climate and mortality in a city in sub-Saharan Africa. So I was pretty lucky to get my hands on this data. So just, here's my agenda for the talk. And just getting right into it, so my motivation is I want to look at the climate and mortality relationship and how it's changed as a city has progressed through the stages of the classical epidemiological transition. And this has a lot of implications for, in addition to climate change vulnerability, also population health in other lower and middle income countries, especially potential vulnerability to reverse health transitions and what the nature of this may be. So the quick background on the city of Antananarivo, it's the capital of Madagascar, population of about 1.2 million, the subtropical highland climate with very distinct, clear, wet, warmer, and cool, drier seasons. And over the past 40 years or so, it's seen two major trends. So one is this epidemiological transition that's been potentially driven by, in addition to improved access to medicines, also to improve water and sanitation infrastructure, and also climate change. So there have been rising temperatures, especially in the drier seasons, and there have been a greater frequency of deadlier floods in recent years. So also a quick background on epidemiological transition theory. So in the classical framework presented by Omran, there are the three stages, which are the age of pestilence and famine, receding epidemics, and the age of degenerative and man-made diseases. And these are basically characterized as mortality, especially from infectious diseases, especially in children, declines over time from a high and fluctuating from a state where it's high and fluctuating to decreasing and then to being low and stable. Obviously, this is from the early 70s. This is kind of an outdated framework. It's been expanded to the broader concept of health transitions, where there can be additional stages, there can be multiple variants depending upon different contexts, and counter transitions as well, where mortality increases. And climate change and emerging and re-emerging infectious diseases play a big role in this an updated framework. So just walking you through the time series of mortality in Antananarivo. As you can see, looking at total population and the population under 5, there have been these three pretty clear stages of the epidemiological transition. Mortality peaked in 1986, and the water, in 1993, where I draw that cutoff, they actually upgraded the water treatment plant. So you do see this decline in enteric infection mortality. And then, however, although mortality stayed low, there has been since 2004 a degradation in the water quality. So I'm looking at how the relationships between climate and directly and indirectly climate-related mortality have changed as the city's gone through the epidemiological transition. And basically, there are kind of two frameworks for looking at direct and indirect climate-related mortality. So direct climate-related mortality is where you have a direct impact of a climatic extreme on mortality. And whereas indirect mortality, you have these environmental mediators with things such as water contamination, vector proliferation, et cetera. So I'll speed up a little bit, but this is essentially my conceptual framework where you have these relationships between temperature and precipitation and climate-related mortality are changed over time as their effect on climate-related mortality is modified by these other factors which change over time, such as infrastructure and population growth, urbanization, et cetera. I use data from the Antananarivo Municipal Bureau of Health, their death registration data, and I use also the Climate Hazard Center data, the CHERTS and SHERTS data for temperature and precipitation, and I also use from INSTAT, the National Statistical Institute, population estimates. So I construct outcomes for looking at mortality rate per 1,000 person years, both under and over, both under 5 and the entire population, age standardized, and I look at both the enteric infection and cause deleted for the entire population is what I'm looking at. And then for my exposures, I look at the mean of daily maximum temperature and total precipitation, and I interact these with the stage of the epidemiological transition. I run generalized additive models. I have a simple lag and I have a cumulative lag, which I define as whatever week it is, and between that and every week between that and a specified week in the past. And I look at the best fit by minimizing BIC, and I run several different models as robustness checks that I'm happy to talk about later. And getting into some of my results, so we see that during the first stage of the epidemiological transition, there's high climate sensitivity overall, and it's become less climate sensitive, specifically under 5 enteric infection mortality. And it's gone from being sensitive to low levels of precipitation to sensitive to high levels of precipitation, and from being more heat sensitive to cooler temperatures. However, when we look at all age cause deleted mortality, we see that it's much less climate sensitive. However, it has gone from being more heat sensitive to being less heat sensitive. And again, I have different model parameterizations and robustness checks that I run as well. So kind of quickly explaining why we might see some of these potential relationships are, so right, we have for under 5 enteric infection, we go from low precipitation sensitivity to high sensitivity to high levels of precipitation. And this can be because the water treatment plant was really upgraded and expanded to cover the city in 1993. And so going from no water source, meaning that there's greater sensitivity to water scarcity, right, from lower levels of rainfall. But when people there is this water source, it can be overwhelmed by these higher levels of precipitation. And that might explain why we see this then positive relationship between precipitation and mortality. Also, thinking about why we might see this transition from mortality being more heat sensitive to being more cool temperature sensitive is potentially these enteric infections really going from being mostly predominantly environmentally mediated to within households. So in standing water, higher temperatures promote pathogen growth. And in unimproved, untreated water sources. However, with this improvement in the water infrastructure, then within household transmission can dominate, and this has been shown by the literature to actually be associated with cooler temperatures. So all of this to kind of sum up, so this is very specific to the Antananarivo context, and these relationships can be very context specific, and they are insufficiently well understood. So some of the conclusions of this work and next steps are so that, first of all, the Antananarivo has gone through a pretty remarkable epidemiological transition. Mortality has both declined and become less sensitive to climate extremes overall. However, there does appear to be a potential vulnerability to counter health transitions from reemerging enteric infections, especially as they've become more sensitive to higher levels of precipitation. And we have seen a lot of heavy rainfall events increasing in frequency in recent years. So this raises potential concerns for this vulnerability. And also, the fast-growing low-income cities in other low and middle-income countries could be similar vulnerability. And another thing this highlights as well is so improving water and sanitation infrastructure is important for climate change adaptation. Really, that is kind of what modifies the effect of precipitation on these mortality outcomes is the the capacity of the water system. And so there is the signs that this water infrastructure is deteriorating and can't keep up with the needs of this growing population. And also, there's a need for further research looking at places with more extreme climates, looking at additional causes of death. Antananarivo does really not have that extreme of a climate, all things considered, and the mortality data, while of good enough quality to be able to look at these really large buckets of enteric infection and everything else, is really not high enough quality to be able to look at these more fine-grained causes of death. So these are, there's a lot of fruitful work to be done in settings with more climate variability, but also have higher quality data, although, of course, those places are hard to find. And I'd like to acknowledge my committee members at Princeton that have helped me on this paper, as well as another one of my external committee members, Deborah Balk, and Catherine Grace, who is here, and as well as Bruno Mascalier has provided me with the data, and I've gotten a lot of feedback from the Princeton Disease Groups and Office of Population Research. Thank you so much.